There's a lot to cover in valvular disorders. This is going to be a long one. What I'm going to do is prepare you for the test to get you ready to identify murmurs and answer the questions that they're going to ask. We're also going to cover murmurs in general. The way you're going to get these questions on the test is a picture of a body. You click to place the stethoscope on one of 4 regions. You identify the murmur by what it sounds like, and you answer a question, either what's the diagnosis or how do you treat it. We're going to go through 4 major murmurs that all respond to more blood in the heart, more murmur, and then talk about 2 additional murmurs that obey less blood in the heart, more murmur. We're going to incorporate auscultation with physical exam maneuver, and then we're going to begin this lecture with murmurs in general. Let's start off with grading and diagnosis of murmurs because it's going to be the same for all the murmurs thereon. And then we'll get into each of the individual murmurs, all 6, one at a time. The first thing you need to know how to do is grade a murmur. And murmurs are graded on a scale of 1 to 6. Grade 1 murmurs are where the normal heart sounds, S1 and S2, are louder than the murmur itself. Grade 2, therefore, where the sounds of the heart are equal to the murmur. Grade 3, S1 and S2 are softer than the murmur. That is, the murmur is louder than S1 and S2. After that, it gets difficult to understand why it's graded 4, 5, and 6. 6 is going to be hearing the murmur without a stethoscope. You won't see this. But you might see grade 4 and 5. The way you separate 4 and 5 is by 4 having a palpable thrill and by 5 being almost 6. You can hear the murmur with a stethoscope half off the chest. You only have to work up our murmur if it is systolic grade 3 or more. Or any diastolic murmur. And when you find a murmur that's systolic, grade 3 or more, or any diastolic murmur, you're going to diagnose it with an echocardiogram. And so as we go through these murmurs, I'm not going to say the diagnosis is made by echocardiogram. Get a chest x-ray and EKG to confirm any details that might clue you in. The focus of this lecture is going to be on identification of the murmur by auscultation. That's what the test wants you to do. And they're not going to ask you to grade on the exam, but you'll have to grade on the wards. And know that if you hear a murmur, get an echo. So let's start off with some of the different murmurs. We're going to start with mitral stenosis. Mitral stenosis, we're going to use the 2-chambered heart system. That's an atria. This is the ventricle. In mitral stenosis, the mitral valve gets thickened and stenotic. The consequence of a thickened valve is that not a lot of blood will get through. And instead, blood is going to back up into the atrium. When blood backs up into the atrium, it's going to cause a dilation of the atrium. And blood backing up into the lungs. So atrial stretch and fluid in the lungs are going to drive the symptoms. The pathology of mitral stenosis is going to be rheumatic heart disease. And because it's rheumatic heart, the patients are generally going to be younger. That is, they're not as old as the aortic stenosis patients with calcification. This isn't calcification. This is inflammation of the mitral valve. So mitral stenosis patients are going to be younger, in their 20s and 30s, and they're going to present with the symptoms of atrial stretch and heart failure. So they'll have CHF symptoms, dyspnea on exertion, paroxysmal nocturnal dyspnea, and crackles on their lungs, or from atrial stretch, AFib. The diagnosis is going to be made by auscultation. The problem is blood flowing across the mitral valve during diastole. That's when that happens. So it's going to be a diastolic murmur. It's diastolic, and because it is a mitral murmur, it is heard best at the cardiac apex, usually found at the fifth intercostal space, mid-clavicular line. It's going to be diastolic with an opening snap. And the opening snap is the thing that gives this murmur away. It will be described as a rumbling diastolic murmur with an opening snap. The treatment is unique. All these other murmurs will not be amenable to balloon valvuloplasty. You essentially do an angioplasty of the valve. Because it's rheumatic heart and not calcium, you can go in with the balloon, dilate it, and open up the mitral valve such that the blood will flow through normally again. You, of course, want to engage the therapy prior to the onset of CHF or AFib. You can wait, though, because the patient may be asymptomatic and simply have asymptomatic mitral stenosis. But what I don't want you doing is trying to remember the indications for intervention. What you need to be able to do for the test is identify the murmur and then know its therapy. For mitral stenosis, it's balloon valvuloplasty. Ultimately, you can do a valve replacement. The reason why you don't jump right to replacement is because in order to replace a valve, the patient needs a sternotomy. You cut their chest open, just like doing a cabbage. Our valves don't last that long, and these patients are young. So if you start with replacing the valve, what's going to happen is that valve will need to be replaced again and again. And so they're going to have to continually have sternotomies throughout their life. Balloon valvuloplasty is done essentially through left heart cath. So no surgery is needed, just a cath. So to review, mitral stenosis, rheumatic heart disease, young patients who develop AFib or CHF with a dilated left atrium on echo, you're going to hear it as a diastolic murmur at the apex over the mitral valve spot with an opening snap. The treatment is going to be balloon valvuloplasty, and balloon valvuloplasty only is correlated with mitral stenosis. This is a diastolic murmur. Let's talk about the other diastolic murmur, and that is aortic insufficiency. In aortic insufficiency, the mitral valve is working fine. The left ventricle has a valve that leads to the aorta. Only instead of being normal, it's weak and floppy. Weak and floppy valves allow blood to flow back into the left ventricle during diastole. More blood in the heart is going to lead eventually to heart failure. So they're going to have a big, dilated, floppy heart. And that's a product of a floppy valve. The left heart's going to fill with blood as more blood fills during diastole. And of course, it's going to fill normally through the mitral valve during diastole, so this extra blood kind of just pools in there and gets stuck. The pathogenesis of any insufficient murmur is going to be infection or infarction. You're either going to have endocarditis destroying the valve or an infarction tearing the valve itself or any of its muscular attachments. One other way that aortic insufficiency can happen is with an aortic dissection. It is a proximal dissection that kind of comes back down the aorta and rips open the aortic valve. The patient presentation is going to either be acute or chronic. Valvular rupture sounds like a bad thing, and it is. If you don't have a valve, blood just goes in any direction. So if you have an acute loss of the aortic valve, either from infarction, infection, or dissection, you're going to have cardiogenic shock. You're going to have poor forward flow, and you're going to have flash pulmonary edema. If you have aortic dissection, you'll also have a tearing chest pain. In the more chronic, insidious onset of aortic insufficiency, the problem is going to be primarily the CHF symptoms. So you're not going to have flash pulmonary edema or cardiogenic shock, but you will get CHF. Dyspnea on exertion, paroxysmal nocturnal dyspnea, and pulmonary crackles. But because the coronary vessels fill during diastole, if instead the blood goes into the ventricle instead of the coronary vessels, you may also present with chest pain. So the presence of chest pain in your vignette does not help you, but the acuity of the situation does. The diagnosis is going to be made by auscultation. Because it is a diastolic murmur, you'll hear it in diastole. Because it's an aortic murmur, you'll hear it at the base of the heart, second intercostal space, right sternal border. It too is defined as a rumbling murmur, but there's no opening snap. So a diastolic murmur heard at the base on the right side is going to be an aortic insufficiency, and you're going to have to replace this valve. There's no waiting. If it's acute, the replacement is going to be emergent. If it's chronic, it is urgent to elective. But regardless, it is a replacement, generally before the onset of angina or heart failure symptoms. So if we now continue with the theme of the aorta, let's go on and talk about the other aortic murmur, aortic stenosis. Aortic stenosis is the exact opposite problem. Mitral valve works fine, but instead of having a loose and floppy valve, you have a stiff one that doesn't want to open. What happens is that very little blood gets through the aortic valve because the heart is pushing against this incredible resistance right at the aorta. So the heart responds to increased resistance by dilating. And what happens is you end up with heart failure. You get a big, loose, floppy heart. Same result as aortic insufficiency, only on a different mechanism, because you have a stenotic valve. Now the blood is going to pool in a loose, floppy heart, and you're going to get primarily heart failure symptoms. The pathogenesis of aortic stenosis is atherosclerosis, calcium deposition. The patients who get atherosclerosis get aortic stenosis. So what you're going to see is the old man with atherosclerosis. And conveniently, aortic stenosis, AS, atherosclerosis, AS. Old men with atherosclerotic disease get aortic stenosis. And because they have atherosclerosis and they're old, they're primarily going to present with chest pain. They may also present with heart failure symptoms or syncope. If you see the old man with atherosclerosis, think aortic stenosis, and then you confirm your diagnosis with auscultation. Because blood is leaving the ventricle trying to get into the aorta, it is a systolic murmur. Because it is aortic, it is heard best at the base of the heart, right sternal border. It will be defined as a crescendo-decrescendo murmur. A systolic murmur heard best at the base, crescendo-decrescendo, in an old man is aortic stenosis. The treatment is not valvuloplasty. You cannot use a balloon valvuloplasty in aortic stenosis because it is about calcification and aortic stenosis. You cannot pop open that valve with a balloon, so you need to replace it. The presence of someone who has a bicuspid aortic valve simply accelerates calcium deposition and may accelerate the age at which you see aortic stenosis. Finally, we're going to conclude with the other systolic murmur, back to the mitral valve, mitral insufficiency. In mitral insufficiency, the mitral valve leaflets don't come together. And this causes blood to leave the ventricle both through the mitral valve and through the aorta, and it will take the path of least resistance. Since more blood is able to leave the heart because there's less resistance, you might even find an increased ejection fraction on that echocardiogram. But what happens is that the regurgitation through the mitral valve increases the pressure in the atrium. So what you're going to get, much like in mitral stenosis, is a big dilated atrium. The left ventricle will essentially be normal. This is going to cause blood to go back into the lungs and left atrial stretch, so you're going to get AFib and CHF symptoms. The way you get mitral insufficiency is the same way you get any insufficient murmur. The path is going to be infection and infarction. The patient presentation is either going to be acute or chronic. See the parallels to aortic insufficiency. The acute presentation is going to be in cardiogenic shock with flash pulmonary edema. It is going to need an emergent valvular replacement. The chronic, more insidious form of mitral insufficiency is going to present with heart failure symptoms and maybe AFib because of the left atrial stretch. The diagnosis is made by auscultation. It is a mitral murmur, so it's going to be heard best at the apex. Because blood is leaving the ventricle during systole and crossing the valve, you're going to hear a systolic murmur. It will be described as high-pitched and blowing, but holosystolic murmur is the key. Holosystolic means that you will hear the murmur and you may not even hear S1 or S2 because the murmur exists for the entirety of systole. The treatment is replacement. And if it is acute and devastating, that replacement must be done emergently. If it's chronic, it can be delayed, but ultimately you have to replace the valve before CHF and AFib set in. So I just want to step back and take a look at these murmurs and compare them. If you have an insufficient murmur, the pathogenesis is essentially going to be infarction or infection, and it can be acute or chronic. The acute conditions for insufficiency is going to be cardiogenic shock. They need replacement immediately. Differentiate aortic insufficiency from mitral insufficiency based on the sound of the murmur and the echo. Stenotic murmurs are generally more insidious in onset and have to do with either atherosclerosis in the case of aortic stenosis or rheumatic heart disease in the case of mitral stenosis. It's going to be insidious in onset, so you're going to have more of an AFib CHF presentation than acute and devastating presentation. When you have a mitral stenosis, it's diastolic. When you have an aortic stenosis, it's systolic. When you have a mitral insufficiency, it's systolic. Aortic insufficiency, diastolic. It's more important since when you're on the computer, you're going to place the stethoscope. Aortic murmurs are going to be at the base, right sternal border. Mitral murmurs are going to be at the apex, fifth intercostal space, mid-clavicular line. Now, last thing before we close on these is two things. Aortic murmurs can be replaced, but when you replace them, because the ostia of the coronary vessels are in the aortic valve, you have to also consider both aortic stenosis and insufficiency for simultaneous coronary artery bypass graft. If you lose that ostia, do you lose coronary flow? The last thing is all 4 of these murmurs follow the same principle. More blood in the heart, more murmur. So anything that you do, any physical exam maneuver that increases venous return is going to worsen these murmurs. The way you increase venous return is by squatting or doing a leg lift. The way you decrease venous return is with a Valsalva maneuver. Valsalva will make these murmurs better. Leg lift and squatting will make these murmurs worse. This is important because as we move into the last 2 murmurs, they obey a completely different physical exam maneuver schema, but they may trick you into hearing one of these murmurs. So it is the response to the physical exam that is going to give you the answer, which diagnosis is it. So as we cross this line, we move over into more blood in the heart, less murmur. The 2 murmurs we have left to close with is hypertrophic cardiomyopathy and mitral valve prolapse. In hypertrophic cardiomyopathy, we talk more about this in the cardiomyopathy section. But what happens is the atria is normal, mitral valve is normal. And the pictures I was drawing aren't exactly accurate because this is the ventricle and the aortic outlet is here. And in hypertrophic cardiomyopathy, what happens is there is a unilateral septum hypertrophy, which essentially grows out and covers the aortic opening, leading to a left ventricular outlet obstruction. The reason why there is more blood in the heart, less murmur, is because you're going to essentially expand the ventricle, revealing the aortic outlet. And if they get dehydrated, the lumen of the left ventricle closes and essentially you lose the ventricular outlet. This loss of the ventricular outlet causes sudden death. The patients who get hypertrophic cardiomyopathy are going to be people who have sarcomere mutations. And there's no one mutation you need to remember. The patient is going to be young and they're going to be an athlete. Now, what everyone remembers about hypertrophic cardiomyopathy is the young athlete who has sudden death. But you will not find people with sudden death because they're already dead. You're going to see patients who are alive. So the patients you're looking for are the young athletes that when they exercise, they worsen their ventricular outflow obstruction and they get either shortness of breath or syncope with exertion. The other way you can identify these patients is by having someone in their family who had a sudden cardiac death. You are going to listen to them. And because it's left ventricular outlet, it sounds like aortic stenosis. You basically block the aortic valve. So you're going to hear a systolic murmur. But it's like aortic stenosis, except that more blood makes it better. If you think this murmur is aortic stenosis, and it is not an old man with atherosclerosis, think about cardiomyopathy and have them do a leg lift or a squat, because you are going to make the murmur better. Regardless, you're going to get an echo and you're going to see the hypertrophied septum. But on the test, you're going to have to differentiate hypertrophic cardiomyopathy from aortic stenosis based on the age of onset and the response to physical exam maneuvers. More blood in the heart, less murmur. The treatment is to, quote, avoid dehydration and beta blockade. You want to slow down the heart rate to increase diastole, to increase filling time, and you want to maintain preload as best you can. Patients with hypertrophic cardiomyopathy cannot exercise. They cannot do anything that increases their heart rate. They cannot do anything that dehydrates them because they will die. The other murmur, more blood in the heart, less murmur, is mitral valve prolapse. And in mitral valve prolapse, what happens is that the leaflets of the valves don't touch well. They don't touch well because they're too big. So what happens is that during systole, they're supposed to close and touch. What happens is they blow through because they're too big. And they're too big, so they don't close right. But if you stretch out the ventricle, the valves come together better, which is why the murmur gets better with more blood. It's difficult for me to draw on the board. But basically what we're looking at is a narrow valve area with the valves that are too big and floppy, so they touch together, but it allows blood to come through. This is the atrium, this is the ventricle. If you make a bigger ventricle with a bigger valve area, these leaflets now have room to come together. And blood does not flow back through the mitral valve. I want you to see that this is blood going through the mitral valve during systole. So you might think this is mitral regurgitation. But mitral valve prolapse is mitral regurgitation that gets better with more blood in the heart. The pathogenesis of mitral valve prolapse is usually simply congenital. You're going to see it in young women. And the diagnosis is made when you hear mitral regurg, but better with more blood. So a young woman who has not had rheumatic heart disease, who has mitral regurgitation, but it's better with more blood, heard the same murmur, but better with more blood, that is leg lift or squatting, probably has mitral valve prolapse, diagnosed definitively by the echo, and the treatment is avoid dehydration and beta blockade. This does not need to be replaced. So let's talk about these two murmurs in particular and identify how the treatment follows the physical exam maneuver. In hypertrophic cardiomyopathy and mitral valve prolapse, the treatment is beta blockade and avoidance of dehydration. Why? Because you want to improve diastolic filling by having more diastole, more time to fill the ventricle, and avoid dehydration so that you sustain preload. That makes the ventricles bigger and avoids the pathology of the murmur. It makes sense then, because you want to treat this patient by having more blood in the heart to reduce the murmur, the physical exam maneuvers that you do that increase blood flow will make the murmur better. Leg lift and squat make hypertrophic cardiomyopathy and mitral valve prolapse better. Valsalva make them worse. The opposite is true of the other four we talked about. Because more blood in the heart makes more murmur, the goal is to either replace the valve or reduce the amount of volume coming back. So if you have to medically manage any of these patients, the goal is going to be afterload reduction and diuresis. I want you to remember, though, that it is replacement for all of these, but you can attempt medical management by having there be less blood in the heart, so less murmur. That is, remove preload and increase the amount of blood that goes forward. So this was a long one, and it actually is easy points on the exam. If you can identify the sound of a murmur based on its location or whether it's systolic or diastolic, you're 90% of the way there, because half of the questions ask you, what's the murmur? You have to remember about the distractors, hypertrophic cardiomyopathy and mitral valve prolapse, which get better with a leg lift or squatting, and worse with Valsalva, the opposite of what you expect from the typical murmurs you'll be tested on. If you can do that, remember that everyone responds to replacement except for mitral stenosis, balloon valvuloplasty, and hypertrophic cardiomyopathy and mitral valve prolapse, beta blockade and avoidance of dehydration. You have about 99% of the questions already answered. That is valvular disease.